slides, but it's okay. So what is task sharing? Just briefly, it refers to an expansion of the levels of healthcare providers who can appropriately deliver a health service. So you may decide to task share the entire task or just components of it. So when we talk about task sharing, we're not saying that we're removing the task from one provider and taking it to another, but rather that two providers can perform the same tasks. And here we're looking at nurses, midwives, clinical officers, and community health care providers, and the number of reasons why we task share and which particular services we can task share. So what's the relevance of post-abortion care? We see that in sub-Saharan Africa, 1 out of every 150 women with unsafe abortion actually die from these complications, and this is the highest in the world. When we come to Uganda, which is in the East African region, according to the NPDSL report that was released 2019-2020, 8% of the maternal deaths are actually abortion-related. However, we know that abortion-related mortality is almost entirely preventable. So WHO proposed a number of methods of uterine evacuation, and this speaks to the emergency treatment arm as part of post-abortion care when women actually come with abortion complications to receive care at the health facility. So in the second trimester, what's recommended for incomplete treatment of incomplete abortion, we can actually use misoprostol, manual vacuum aspiration, dilation and evacuation. And the last one that you see there, B and C, is actually not recommended, although I know it's a practice that most of us still do up to now. So why second trimester? Because we know that a lot of mortality from abortion complications occurs in the second trimester period. A paper we published in the BMJ about a year or so ago showed that there were more abortion-related deaths in the second trimester compared to the first, and this also relates to the previous research that has been done in the area of abortion care. A number of studies have been done on task sharing in the first trimester, and actually by the time we initiated this study, there was no documented study on task sharing in the second trimester. And if you look at the WHO abortion care guidelines that were released this year, there is no evidence in there, and it's a gap that was highlighted, making this study very relevant. So what was the general objective? It was to compare the safety, effectiveness, and acceptability of medical treatment of incomplete second trimester abortion when provided by midwives versus physicians in Uganda. And our study hypothesis was that the treatment outcome in terms of complete abortion among women that were managed by midwives would be equivalent to that among women managed by physicians within a predefined equivalence margin of -5 to +5%. So this was a multi-center randomized control clinical trial. The study was done at 14 sites. So we initially started with 8 sites. And then as we noted that accrual was a bit slow, we had to add another 6 sites, making them 14 sites. In 11 districts, central region of the country. Why the central? Because at that time, the central region of the country had reports of a higher incidence of abortion compared to the national average. So here in the central region was about 56 women, 56 induced abortions per 1,000 women compared to the national average of 39. So all these facilities were public health facilities that were offering comprehensive emergency obstetric care services. And we know that a facility that offers comprehensive emergency obstetric care services will usually have a doctor and a midwife. So we had 4 health center 4s, 8 general hospitals, and 2 referral hospitals. The Health Center FOS is the first level health facility that offers CMOC services in the country. Who were the participants? We included women with signs and symptoms of incomplete abortion, and they had to have a uterine size between 13 to 18 weeks. We then excluded women who, yes, had this, but needed urgent treatment. So for example, if someone had sepsis, or they were hemodynamically unstable in terms of the vital signs, or maybe they had heavy vaginal bleeding, severe abdominal pain. So those ones you cannot treat with misoprostol, they would need a surgical evacuation. And then we excluded women who are allergic to misoprostol, because we mainly use misoprostol, the drug. And then women who had other forms of abortion, like a molar abortion, or maybe a suspected extrauterine pregnancy, because the management was different. So I was looking at previous slides and I was wondering what happened to the contestant slides, but I think it's the formatting. Yes, so the study inception, we obtained the necessary ethical approvals and then proceeded to do health facility sensitization talks. Why was this important? To be able to familiarize the healthcare providers about what the study was about. And because these are different contexts, we needed to understand the modalities of how they provide their services so that it could help us improve the implementation of the study. And during these talks, we tasked the healthcare providers to identify the individuals who would be involved in the study, and then these were later on trained, later on came to Kampala for a 2-day training. So we trained over 183 healthcare providers. We engaged the Ministry of Health at the inception, right from the start, to inform them of what we're doing, because like the advocacy, people in advocacy will tell you, engagement, if you want your results to be taken up by the policymakers, it's usually very important to engage them right from the start and also get their view on how the implementation can be done better. So we got an independent statistician who made a computer-generated blocked randomization list, and we had random blocks of 4 to 12, so that the research assistants will not be able to, like sort of predict who the next arm could be. And then we use sealed, numbered, opaque envelopes. Now, it was difficult to blind the healthcare providers or the patients, because if someone's going to be worked on by a doctor, most likely they are already dressed up in a coat and probably have a name tag. So the participants were not blinded to the study arm. And however, we used codes to conceal the allocation groups to the data entrance so that they would not be able to know that probably this participant, this data belonged to participant that was worked on by this particular random allocation group. So we performed supervision visits every 2 weeks to ensure adherence to the study protocol, and also troubleshoot in case of any issues that arose. I need help. I think it has frozen. Yes. So at all the health facilities, women with abortion complications were screened by midwives, and we had a predefined checklist. And then those who accepted to join the study gave informed consent. And it's at that point that the research assistants then picked the envelope that was already, and then got were able to know the allocation group, and then assigned the participant to the allocation group. And then within that group, whether it was a doctor or physician, they would undergo clinical assessment. So the history taking, the physical exam, and then after that, they would then get the treatment. And the dose regimen that we're using was that was recommended by the WHO in 2012. So that was 400 micrograms sublingually, 3 hourly, even 3 hourly, for a maximum of 5 doses, or until a complete abortion was confirmed. So you may find that there are some women, you give the first dose and then they get a complete, or you give the third dose and then they get a complete. And then before a subsequent dose of misoprostol was given, we would assess vital signs and also check for presence of side effects. So this was for purposes of ensuring that whatever we're doing was safe. So once an expulsion occurred, then we would diagnose a complete abortion, and that was by clinical assessment. And this would then be verified by an independent assessor, who would be another healthcare provider in that same arm. Now, there are some participants who maybe reached the 24-hour period and had not achieved a complete abortion, or during the 24-hour period, their clinical state deteriorated. So those would be would then be taken for a surgical evacuation by the doctor. So all the participants were expected to come back at the 2 weeks follow-up visit. However, at the initial visit, whatever we're doing was inpatient care, still for purposes of safety. And then we also offered them analgesics, prophylactic antibiotics, contraceptive counseling and provision as part of the package of post-abortion care. Okay, so our primary outcome was a complete abortion without any surgical interventions within 24 hours of treatment initiation, and this was based on clinical assessment. We had a number of secondary and safety outcomes as well. I'll skip that in interest of time. Okay, so the trial was registered, which is good practice. We had the study protocol published, and the main manuscript was recently published in the Lancet Global Health last month. So when we had accrual of slightly over 50%, we had the DSMB review the data for safety, and we collected our data from July 2018 to November 2021. So that was a period of 3 years. So for anyone who's planning to replicate the study, you need to give yourself ample time for data collection. So over the period of 3 years, we assessed 7,190 women, and out of those, we randomized 1,191. 598 were allocated to the physician arm, and 593 were allocated to the midwife's arm. One patient in the physician's arm actually ran away from the facility, so we don't have a lot of information about that one. And then we excluded from the analysis. So our intention to treat population, what we took as our intention to treat population was a participant who was randomized, received at least 1 dose of misoprostol, and had primary outcome data. And then our per protocol population was a participant who was randomized, received at least 1 dose of misoprostol, had primary outcome data, and did not have premature discontinuation from treatment. So what did we define as premature discontinuation from treatment? So we know, so as we were assessing these women, there are some women who got a surgical evacuation. However, from the records, there was nothing to suggest that maybe they had a deteriorating clinical status. And I think we all know the monetary incentives that are behind evacuation in our facilities. So that is a challenge that we faced, and it's something that we knew was ongoing, and that's why we kept having continuous engagement with the healthcare providers. So those are the participants that we defined as premature discontinuation from treatment. So our trial results, so our background characteristics, when we compare the background characteristics between the women that were managed by the physicians and those that were managed by the midwives, there was no statistical difference, meaning that the randomization actually did go on well. Out of the 1,083 women, we had 93% having a treatment success, 92% in the midwife arm and 94% in the physician arm. So meaning that our risk difference was minus 2.3%. And if you look at the confidence interval, both the estimate and the confidence interval lay between our predefined equivalence range, meaning that there was an equivalence between the two. So we attained a higher treatment success rate compared to our priori assumed complete abortion rate, because when we were estimating the sample size, we actually used a success rate of 90%. However, we note that 93% is slightly lower than previously published rates of 94 to 96% that we see in first trimester PAC. And for these results, we use a generalized linear mixed effects model with the healthcare provider as the fixed effect and the health facility as the random effect. When we look at the secondary outcomes, we see that 23% of the participants actually got some side effects. So all the secondary outcomes do not significantly differ between these two study arms, except for unscheduled visits, where 3% were in the midwife's arm and 2% in the physician's arm. 2 women in the midwife's arm received a blood transfusion, but they recovered well and were discharged. The total median dose of misoprostol that we gave was actually 1,200 micrograms, which translates to 3 doses. Remember, we're giving a maximum of 5 doses. So median 3 doses were required for over 50%. The median time from administration of the first dose of misoprostol to achievement of a complete abortion was about 6 hours. And the median duration of admission in the facility was about 21 hours. So in addition to this, we decided to look at acceptability from the patient's angle. And this was mixed methods. So in addition to the RCT, we did some in-depth interviews for 28 patients with maximum variation sampling. And what we used as overall acceptability was a composite variable of treatment experiences and satisfaction. And generally 94% of the participants had satisfactory acceptability, and the acceptability was equivalent between the midwives and physicians groups. So the other things that came out was, so we compared the demographic characteristics against overall acceptability, and what came out in addition to the qualitative results, we see that treatment success, feeling calm and safe were key determinants of satisfactory acceptability. And then experience of side effects and worrying bleeding patterns actually reduced acceptability. So we now shifted from the participants and looked at the healthcare providers to also now get their views and their experiences of having participated in this study. And we did this 1 year after we had started data collection. So we collected this data between June and July 2020, and we interviewed about 48 healthcare providers. And the key things that came out was that misoprostol, given misoprostol's ease of administration, trained midwives can competently manage these patients in a health facility if they have a backup of a doctor. Misoprostol was seen as safe, convenient, saves resources, and it was highly favored as a uterine evacuation method for second trimester PAC and complicated patients. So still from the healthcare providers' views, we saw that misoprostol side effects and managing appropriate dosing actually affected patients' response to treatment, because when patients experienced side effects, some of them would actually pretend to put the drug under their tongue, and when the provider would go out, they would remove it because this was an effectiveness study. So we chose effectiveness because we wanted to mimic the real clinical situation, that transiting from the RCT, if we went into actual practice, what would the response be? There were institutional and policy-related issues like work overload, lack of drugs and supplies, lack of space, few doctors. So this really depicted the overstretched health system. However, the healthcare providers had some coping mechanisms. So these included counseling, the participants, encouraging them to take their medicine, reassurance, and involving the patients in their care plans, meaning that sometimes they would actually tell the patients to remind them when the time was due for them to get their next dose of meds. In conclusion, misoprostol treatment of uncomplicated second trimester incomplete abortion is equally effective, safe, and acceptable when care is provided by midwives compared with physicians. The healthcare providers actually perceive that trained midwives can competently manage these patients in a health facility with a backup of a physician. And we see that treatment success and feeling calm and safe enhance acceptability, while side effects and worrying bleeding patterns actually reduce acceptability. Counseling, reassurance, and patient involvement are proposed effective strategies that may address the challenges of side effects and appropriate dosing. So our key recommendation from this study is that to improve accessibility of post-abortion care, we need to include midwives in the provision of services for uncomplicated second trimester post-abortion care through Ministry of Health policy guidance and programming. Thank you.